Now we can. Yeah.
You can wait 1 more minute.
Yes,
Let
sir.
others join. Attendee join. They are joining here.
Yeah. So now it is open, then now people will join.
Okay. Okay, Amit, you go ahead.
So, uh, good morning, everyone. I am Dr. Amit Shankar Singh from Fortis Hospital, Mohali, and the convener of IN Headache Subsection. I welcome you all to this interesting explicit headache quiz about mastering ICSD-3 headache classification. We have with us our IN headache subsection chairperson, Professor Sanjay Prakash, who actually conceived and sculpted the idea of headache quiz in this forum. And we also have two esteemed panelists with us, Dr. M.B. Francis, sir, headache and neuro-ophthalmology specialist from Kerala, and Dr. Vimal Kumar Paliwal, sir, Professor, Department of Neurology, SGPGI, Lucknow, with a specialization in headache disorders. The quiz master of this quiz will be Dr. Manju Yadav from SBKMS Medical and Research Institute, Vadodara. And this quiz will be in two parts. Part one with primary headache and part two, secondary headache. And after each part, there will be discussion about the answers and discussion between the panelists. Now over to Dr. Sanjay Prakash for an overview and concept of this quiz.
Oh, thank you, Dr. Amit. I just in a start welcome everyone to this headache subsection quiz, which is exclusive on the headache quiz. We have no lecture in this subsection meeting. And as you mentioned, we are fortunate to have two experienced headache experts as our panelists today in today's subsection meeting. It is a pleasure to introduce Dr. M.B. Francis, sir. He is the Vice President of the Headache Society of India, and Dr. Francis is widely respected for his remarkable command on the ICSD headache classification. And he remembers almost every criteria. We are fortunate to have him with us today, sir. Thank you, sir, for being here. And
Thank you.
Thank you. And our second panelist, Dr. Vimal Paliwal, is the professor of neurology at SCPGI. And he has worked almost every aspects of the headache. So thank you, Vimal, for being with us.
Thank you, sir. Thank
And
you for inviting.
today's quiz will be conducted by Dr. Manju Yadav, who has prepared this excellent and challenging set of questions. Thank you, Dr. Manju, for taking the effort to design these questions. And before we begin, let me briefly share the view why we have started. This is not just examination. The primary object of today's quiz is to just stimulate interest in the headache by especially among the resident or neurologists. As we all know, in MBB, even MBBS, MD, even DM, there is almost no teaching for the headache parts. So many students almost never learn, at least actively in headache subsection, headache medicine. So, keeping in that in this view, we have organized this quiz, and we all know that ICSD classification is a very long classification system, and I don't think anyone can read all. But my feeling is that every physician, whether it is neurologist or just general physician, everyone should know the classification or criteria of the at least primary headache disorder. And secondary headache disorder can be of the ICD-3 classification, can be used as a reference book. So today's quiz just inspires any of the resident of the neurology resident, and we will consider today's program as successful. So keeping in that mind, we will go for this quiz session. And now I will over the session to digital team Smita and Dr. Manju. Dr. Manju, you will just highlight the how will we proceed and
Yes, sir.
other
Yes, sir.
things.
Thank you, sir. Good morning, everyone. So, welcome to today's ICSD 3 MCQ session. And please listen to the following instructions carefully. So, as already discussed, that quiz will be conducted in two parts. That is 20 questions in each part. And after each part, we'll be having a quick discussion session for the answers. Each correct answer carries 1 mark for the right answer, and there is no negative marking. And you will be getting 40 seconds for each question. Also, please note that you have to submit your response before the time for each question ends. Once submitted, the response cannot be changed. And I will read out loud questions only. The answer options will not be read loud. So please read them carefully on your own screen. Also, if you are attending on mobile phone, please turn on the auto rotation so that you can view the complete question and the answers clearly, especially the lengthier ones. That's all. I wish everyone all the best, and let's begin with the part one first.
So part 1 includes only primary headache, question on the primary headache disorder.
So section 1.
Okay. Can we start?
Yeah.
Question number 1.
Question 1. The typical sequence of multiple aura symptoms in patients with migraine with aura is which of the following?
Ten seconds. Question number 2.
Question number 2. Patient experiences recurrent visual aura before headache. Which of the following aura profile does not provide sufficient characteristic features to satisfy the ICSD-3 diagnostic criteria for migraine with typical aura? Okay, 2 of them have commented not seeing the questions.
10 seconds remaining.
Smita, can you please check?
Okay, those who are not able to see the question, please click on the poll action. There is an option of poll. You have to click that poll option.
So can we start again? Because someone has not seen.
Okay.
Hello,
So,
Smita.
Sure, sir. Dr. Manju, we can start from the
Yes,
first
sir.
question.
Yes,
again.
yes, doctor. So question 1 again. A typical sequence for multiple aura symptoms in patients with migraine with aura is which of the following?
If participants are not seeing again, just message it.
10 seconds remaining.
Smita, you can ask if they are seeing or not. Before second question, just we should verify.
Hello, participant, please drop a message if you are not able to see the questions.
Yes, it's visible. Someone has written.
एक ने लिखा अभी भी unable to see.
Not seeing them still.
Because we are seeing the questions. Dr. Paliwal and Dr. Francis, you are able to see the questions?
Yes, we can see.
We are
Yeah,
seeing
we
it.
can. We can, no
Yes.
problem.
Yeah, ठीक है.
So can Dr. Manju, can we go ahead with the second
Yeah,
question?
yeah, sure,
Yeah,
sure.
now we can move.
Sure.
Maybe we can repeat first 2 questions later in the end.
No.
Question number 2. Patient experiences recurrent visual aura before headache. Which of the following aura profile does not provide sufficient characteristic features to satisfy the ICSD-3 diagnostic criteria for migraine with typical aura? After locking the option, please don't forget to click on the submit button.
10 seconds remaining. Question number 3.
Question 3. A 46 years old woman has headache on 20 days per month for past 1 year. The headache is bilateral, pressing, moderate, and not worsened by activity. All of the following associated symptom patterns are compatible with chronic tension type headache except
10 seconds.
Question number 4. A patient has fully reversible attacks of vertigo, dysarthria, and tinnitus preceding the headache. Which additional single feature would exclude migraine with brainstem?
Ten seconds remaining.
Question number 5. According to ICSD-3, which of the following is not included among the cranial autonomic features of cluster headache?
Ten seconds remaining.
Question number 6. A patient with migraine develops a continuous disabling headache lasting more than 72 hours. According to ICSD-3, the diagnosis of status migrainosus may still be made if the attack is interrupted by a headache-free period of no more than which of the following? Participants can rotate their phone if they're not able to visible the questions and options completely.
5 seconds remaining.
Question number 7. According to ICSD-3, which of the following frequency criteria defines frequent episodic tension type headache?
Ten seconds remaining.
Question number 8. According to ICSD-3, which of the following statements regarding the maximum duration of headache is incorrect?
10 seconds remaining.
Question number 9. A patient presents with recurrent headaches that awaken her from sleep. Which of the following statements about hypnic headache is false?
Yeah. 10 seconds remaining.
Question 10. Which of the following ICSD-3 headache disorders is incorrectly matched with the maximum permitted interval between removal of the triggering stimulus and headache resolution?
Uh, 10 seconds remaining.
Question number 11. Which of the following is not part of the diagnostic criteria for primary thunderclap headache?
But 10 seconds remaining.
Question number 12. A patient has hemicrania continua for 3 years. She reports 2 pain-free periods lasting 2 days each. According to ICSD-3, this clinical course is most consistent with which of the following?
Ten seconds remaining.
Question number 13. A patient develops visual aura followed by unilateral numbness and then aphasia. Which is the maximum acceptable total aura duration according to ICSD-3 for migraine with aura in this patient?
Ten seconds remaining.
Question number 14. A 45 years old man with suspected hemicrania continua is treated with indomethacin 150 milligram per day for 1 week, but reports only mild improvement. According to ICHD-3, what is the most appropriate next step?
Ten seconds remaining.
Question number 15. According to ICSD 3 diagnostic criteria, which of the following clinical profiles is most consistent with paroxysmal hemicrania?
Ten seconds.
Question number 16. A woman with 6 years of episodic migraine now has headache on 18 days per month from 5 months. 9 days are fully migrainous and she takes triptan on 12 days per month. Which coding is correct as per ICSD 3 in this patient?
Ten seconds remaining.
Question number 17. A 39 years old woman experiences 3 recurrent headaches that reach maximal intensity within 15 seconds, each occurring exclusively during orgasm. MRI brain, CT angiography, and CSF examination are normal. According to ICSD 3, how should these attacks be classified?
Ten seconds.
Question number 18. A 44 years old woman has a 3-year history of pain confined to a 4 centimeter round area over right frontal scalp. The painful area has remained unchanged in size and location throughout the illness. MRI brain is normal. The most likely diagnosis is which of the following?
Ten seconds.
Question number 19. A patient simultaneously fulfills criteria for both new daily persistent headache and hemicranial continua. As per ICHD 3, the default diagnosis for this patient would be which of the following?
Ten seconds.
Question number 20, last question for this section. Which of the following statements regarding primary cough headache is incorrect according to ICHD 3 commentary?
Ten seconds remaining. My all first part is done.
Okay. Thank you, Dr. Manju, for this part one. So before going into the answer of this 20 questions, I will ask some question to expert panelists. So Dr. Francis, sir, what is your overall impression of this first section?
Yeah, very, very good, very practical questions. Well crafted, and I must appreciate Dr. Manju for
Thank you.
these, but one
Which
must
question do you
know.
see the most challenging? Is there any challenging in this primary headache questions, or it is simple?
Oh, not that simple. I will not say these are simple questions. You need months of or years of mastery over ICST3 to answer these questions. Yeah, it's not that easy. This is from my 36 years experience. I started ICST1 in 1990-91. Yeah, migraine tension cluster. I happened to see that in British Medical Journal when I was a first year PG.
Okay, thank
So
you, sir.
I think it
Dr.
is
Vimal, your opinion,
difficult.
how
Yeah.
important is familiarity with ICSD3 classification in day-to-day clinical practice, especially for the primary headache disorder, I will ask. Is
I
it
think
required or not?
no, the problem is if you want to diagnose an entity which is given in ICSD, then it has to be as per ICSD3 criteria only, because otherwise we'll gather myths than the concepts. So it is very important to know ICSD. Now it is a different story that it is very difficult to remember everything. So I was actually finding it challenging on the conditions where I have written papers. I was finding it difficult to diagnose with the present set of answers to the question. So it's not
I have
easy. As Francis sir said, it is not easy, but these questions are better made as compared to the first time.
I have feeling that there are just 17 primary headache disorders. So we can remember, even in
Yeah.
that family, 10 other primary easily can be remembered. So I have personal view that at least primary headaches should be remembered by every resident. What do you think?
No, it can be
Otherwise,
remembered.
there is no way to make diagnosis. How would you make
Yeah.
diagnosis?
Yeah. So the commonest way of making diagnosis and not faulting is to refer it to ICSD3 every time. So that way you won't falter. But to answer questions in MCQ is a different ball game actually.
Definitely, definitely.
I
So
think
now
this
we'll
is
move the answers section of this part one, and then later part we will discuss the second part. So Manju, go ahead for the answer part.
Yes, sir. So let's see the answers for the section 1 questions. So the first question, the typical sequence of multiple aura symptoms in patients with aura, answer is C, that is visual, followed by sensory, and then aphasia. For question number 2, patient experiences recurrent visual auras, and the answer which is odd here is C, that is positive bilateral visual symptoms. It has to be unilateral visual symptom and within 60 minutes, followed by headache. For question number 3, where all the options are compatible with chronic tension type headache, except, so answer is D, that is mild nausea with either of photophobia or phonophobia. As the ICSD says that both of the following should be met, no more than one of the photophobia, phonophobia, or mild nausea, means either one of them can be there, not two. Question number 4. Answer here is C, that is motor weakness, where this single additional feature excludes the migraine with brainstem aura. Question number 5. Which of the following is not included among the cranial autonomic features of cluster headache? It's C. So here we have to focus on the pair. The meiosis is present, but facial flushing is not there. So answer is C, facial flushing and meiosis. Question number 6. A patient with migraine develops a continuous disabling headache for more than 72 hours. So, as per the diagnosis of status migrainosus, a remission of up to 12 hours due to some medication or sleep is acceptable. So, answer is B. For question number 7, the criteria for frequent episodic tension type headache, we need to have at least one headache day per month on an average. So answer is A. Question number 8, regarding the maximum duration of headache, the incorrect statement is D. Primary thunderclap headache has a maximum duration of 72 hours. So minimum duration is defined in ICHD3, that is 5 minutes. Maximum duration, however, is not defined. So answer is D. Question number 9. Patient presents with recurrent headache which awakens her from sleep. So among all the following 4 options, the statement which is false regarding hypnic headache is C, that is attacks are linked to light sleep. So ICHD says that hypnic headache is not related to any sleep stage. So rest other options are correct except C. Question number 10, the option which is incorrectly matched with the maximum permitted interval and interval of stimulus and the headache resolution. Answer is D, that is external traction headache is not 4 hours, it's 1 hour. So headache should resolve within 1 hour in the external traction headache after removing the stimulus. Question 11, which of the following is not a part of diagnostic criteria for thunderclap headache? So all the options are correct except D, that is vomiting. Vomiting is nowhere mentioned. Rest other options are fine. Question 12, a patient has hemicrina continua for 3 years and she is reporting 2 pain-free periods lasting 2 days each. So the correct answer is remitting hemicrina continua, in which the interruptions can be of at least 24 hours duration. So answer is B. Question number 13, where patient has 3 auras, visual aura followed by numbness and then aphasia. So the maximum duration is 3 into 60, that is 60 each. It makes out 180. So answer is D. Question number 14, a 45-year-old man with suspected hemicrina continua is treated with indomethacin 150 milligram. So the next appropriate step would be to increase the dose of indomethacin dose before saying it not responding to indomethacin. So answer is B. Question number 15. According to ICHD criteria, which of the following clinical profile is most consistent with paroxysmal hemicrania? Answer is C. At least we need to have 20 attacks, each lasting for 2 to 30 minutes, occurring for more than 5 times a day. So that makes answer C. Question 16, where a patient with episodic migraine has 18 days per month for 5 months, and then 9 days are fully migrainous, and she also takes triptanon 12 days per month. So here, according to ICSD, we have to consider both chronic migraine and medication overuse headache both. So answer is C. Question 17, where a 39 years old woman experiences 3 recurrent headaches, which reaches maximum intensity within 15 seconds during exclusively orgasm. Please note the word exclusively, as she is having episodes only during the act. So answer is B, that is primary headache associated with sexual activity, where attacks can last from 1 minute to 24 hours, and we have to consider option B as answer. Question 18, where 44 years old woman has 3-year history of pain which is confined to 4 centimeter round area, and it's not changed in signs and position location throughout the illness. So answer is C, that is nummular headache. Question number 19, where a patient fulfills criteria for both New Delhi persistent headache and hemicrina continua. So now here, as per ICHD3, we have to consider only hemicrina continua, that is B, as ICHD3 states that when criteria for both are met, then hemicrina continua is to be considered. Question number 20, regarding the primary cough headache, the incorrect statement is D, that is the severity of headache is unrelated to the frequency. But in actual, severity of headache is related to the frequency of coughing as per ICHD3.
Okay, thank you, Dr. Manju. Now some question answer session. Dr. Vimal, I have questions for you. Hello, Dr. Vimal. You are hello, can you hear?
Yes, sir. Yes, sir.
In a clinical practice, how many patients do you think that do not fulfill the criteria of the ICH3, but still you think it is the primary? So that ICH3 may not be useful in that circumstances.
Sir, in my experience, most of the people do fulfill the criteria. The issue is in OPD, we do not remember the criteria exactly. When we write everything about the patient and check the criteria, most of the times I feel that the patient fulfill, except for tax. Tax, sometimes the problem is that you consider a patient to be cluster headache and turns out to be paroxysmal hemicrania. Because phenotypically, both the headaches are very similar and the duration is also overlying. So for cluster like 15 minutes to 3 hours and the paroxysmal hemicrania 2 minutes to 15 minutes. So sometimes there is an issue. And second, there is much of overlap over this first division trigeminal neuralgia and SUNC. That is actually a ongoing issue. So many of our patients actually fulfill both the things. So I'm sure it might have occurred for other headaches also, but at present time I remember these two conditions.
And I think overlap is similarly in the tension type headache and the migraine.
Yes.
So
So the more
mainly-
severe attacks of tension will actually phenotypically similar to migraine.
Yeah.
And on the other days of a month, they'll be like tension type headache. So this is again a very common phenomenon.
So if you stick the criteria, can you make diagnosis or there is problem?
Then it's a issue, sir.
So, Dr. Francis, I have few questions. One is regarding the classification of the tension type headache. In frequent tension type headache, as we have seen here, just one attack per month is enough to qualify it as a frequent. There is no such division in the migraine for the migraine. There is just episodic and chronic.
Yeah.
But sir, in the tension type headache, there is frequent, infrequent, chronic tension type headache. And for the frequent headache, just one attack per month is enough to quantify it as a frequent. How do you see it?
Frequent is, I think, less than 14
It is just
or
1 to
3
14.
months.
One attack is enough to qualify.
Yeah, that is infrequent episodic. If it is one attack a month, I think a frequent episodic is, up to 14, less than 15, and more than 15 is CTTH.
Yeah.
More than 15 is CTTH for more than 3 months, and less than 15, for 3 months is frequent episode. Infrequent is, like one per month. Yeah. That is what I remember. Infrequent, frequent, and CTTH, chronic. Yeah.
Bimal, one question regarding the hemicrania continua. You are again unmuted yourself.
Sir.
So, hemicrania continua in remitting and unremitting variety. Just 1 day symptom-free period is just to differentiate between the remitting and remitting.
So yes, this is something
Oh.
which actually I don't understand why it is so.
We have put this question intentionally
Yes,
just
yes.
to see if there is just one symptom-free period
Yeah.
in 1 year, it is remitting type.
So this is again a very questionable thing. I don't know how it came. I'll have to go into the details how they put 2 days criteria for remitting. So it's difficult.
Okay, any question you will like to discuss, Dr. Francis and Dr. Bimal here?
It is
In this part
written
one?
either with the treatment or with sleep, that less than 12 hours of, remitting hemicrania.
That is for the status diagnosis. I am just discussing, sir, hemicrania continua remitting and unremitting variant.
Yeah.
So I think
That is,
there are many gray areas in ICHT3. Even this ophthalmoplegic migraine was also not very fitting. So I think with the
We
revisions,
have one
that's
question even in that part in the
Yeah.
second section. So
So-
can we move to second part? Dr. Bimal, we can.
Yes, sir.
Ah,
Sure, sir.
So Asmita, Dr. Manju.
So let's move to section 2, which comprises of secondary headaches, neuropathies, facial pains, and appendix. Question number 21. I hope everyone can see the image as well. A 46 years old man presents with attacks fulfilling all diagnostic criteria for cluster headache. MRI demonstrates a pituitary macroadenoma as shown here with biological evidence of hyperprolactinemia According to ICSD 3, the answer should be which of the following?
Seconds remaining.
No, the next page is not coming. Only the
So we can
MRI
scroll
image is.
down. We can scroll down the options. Is it?
You have to scroll down, sir. Otherwise, maximize you are in the laptop, you maximize the questions. Just verify, Manju, if everyone is okay with this
Yes, sir.
question or not.
So,
If anyone has problem, just drop in something, comment in the box.
okay, you can show again this first question. Then, so people have to scroll down the question, then they can see the options.
If anyone has not seen that question, just drop a message. If there is no, we can move. Okay.
Not seen, not visible. People have commented.
Not visible. Question is not visible or is partly not visible.
Dr. Manju, I'll launch active the question number 21 again. We'll ask attendees.
Option not seen. So repeat, Asmita, repeat the question, and whoever is
Actually,
so they
probably
have
there
to
is problem in the scrolling down. They might have not scrolled down.
Sure, sir, I will.
Yes, now we can see. It is visible.
Attendees, please scroll the screen for the options.
Okay.
Ten seconds remain.
Where is Manju? Manju is
Dr.
not-
Amit, Dr. Amit, can you read the question? Dr. Manju has logged
Which of
out
the
of the-
following, I am just reading, which of the following CSF opening pressure threshold is correctly matched with the ICSD 3 diagnostic criteria for idiopathic intracranial hypertension?
10 seconds remaining.
So question number 23. According to ICSD 3, which of the following formulations is not considered a combination analgesics for the diagnosis of medication overuse headache?
Second.
Question number 24 is an image question. A 45 years old man presents with acute unilateral neck pain, ipsilateral facial pain, and a painful Horner syndrome. Axial fat suppressed T1 weighted MRI is shown as below. The high signal crescent surrounding the internal carotid artery most likely represents which of the following?
Ten seconds remaining.
Question number 25. Which of the following is not a characteristic feature of post-dural puncture headache?
Ten seconds.
Question number 26. Again, an image question. A 30 years old postpartum woman has progressive headache, papilledema, and a seizure. Imaging is as shown below. Which statement is true regarding the diagnosis?
Ten seconds.
Question number 27. According to ICSD 3, sleep apnea headache is characterized by all of the following except.
Ten seconds.
Question number 28. A 35 years old man has a severe paroxysmal headaches triggered by certain head positions with transient obscuration and one collapse. MRI is as shown below. The mechanism and the priority for the above image is which of the following?
Ten seconds remaining. Dr. Srinivas, you have to click that image if you want to see in large size.
Question number 29. Which of the following is not a characteristic feature of ictal epileptic headache?
Ten seconds remaining.
Question number 30. A 56 years old man presents with acute severe headache and mildly elevated blood pressure, but has no clinical features of hypertensive encephalopathy. According to ICSD 3, which blood pressure threshold supports the diagnosis of headache attributed to hypertensive crisis?
Ten seconds remaining.
Question number 31. A 40 years old woman presents with recurrent thunderclap headaches and multifocal cerebral artery narrowing on angiography as shown below. Which finding most strongly favors the diagnosis of RCVS, that is reversible cerebral vasoconstriction syndrome, over primary angiitis of central nervous system?
Ten second.
Question number 32. A 42 years old man experiences recurrent severe unilateral periorbital jabbing headaches exclusively during aircraft descent. Each attack resolves within 30 minutes of landing and neurological examination is normal. According to ICSD-3, the most appropriate diagnosis is which of the following?
10 second.
Question number 33. A 39 years old man has a headache that worsens within 15 minutes of standing and eases on lying flat. MRI is as shown below. Opening pressure was low. The most specific treatment for this condition is which of the following?
10 second remaining.
Question number 34. A patient has V1 paroxysmals lasting 30 seconds triggered by touching the face with prominent conjunctival injection and tearing. Which feature most favors shunt over trigeminal neuralgia?
10 second remaining.
Question number 35. In ICSD-3, the entity formerly called ophthalmoplegic migraine is now classified as recurrent painful ophthalmoplegic neuropathy. Which of the following statements regarding ARPON is false?
10 second remaining.
Question number 36. For a diagnosis of classical trigeminal neuralgia, MRI should demonstrate which of the following?
10 second remaining.
Question number 37. A 60 years old man develops brief stabbing pain in the tonsillar region which is triggered by swallowing, followed immediately by a syncope. According to ICSD-3, the syncopal headaches episodes are most likely due to which of the following?
Second.
Question number 38. A 28 years old female has recurrent electric shock-like pain lasting 30 to 60 seconds, but also a mild facial sensory deficit. MRI is as shown below. The correct classification for this patient is which of the following?
Second.
Question number 39. According to ICSD-3, which of the following correctly describes the diagnostic menstrual window for a pure menstrual migraine and a menstrually related migraine?
Second.
Last question, question 40. An elderly man presents with the pain distribution as shown in the image. According to ICSD-3, which of the following is least supportive feature establishing causation of headache of head and neck pain attributed to orthostatic hypotension?
Second. Ma'am, all 40 questions
Okay.
done.
Thank you, Dr. Manju. Now you move to answer section. We will discuss everything in after discussing the answer session.
Okay,
But
sir.
before
Sure.
that, I can see here Ashish Dugal. Welcome here, Dr. Ashish. And for our attendees, if you have any
Thank you, sir.
question,
Thank you.
oh, welcome.
Thank you, sir.
Participant and attendees have any question, just drop a message, drop a question in that message box so that we can take your question in the last. So we will show the answer of this 20 question, then we will discuss and we will take the question of the participants. So Dr. Manju, go ahead for the answer of this part 2.
Am I audible, sir?
Now you are audible.
Yes.
Okay, okay. So coming to the answers for section 2, the first question, question number 21, where a 46 years old man presented with attacks fulfilling the diagnostic criteria for a cluster headache, but he had this image which demonstrates a pituitary macroadenoma. So answer is B. Here it would be coded as secondary attack that is attributed to pituitary lesion, and so we have to treat the lesion. So the answer is B here. Question number 22, which of the following CSF opening pressure thresholds it's correctly matched for the criteria for idiopathic intracranial hypertension? Answer is B, For adults, the cutoff is more than 250 mm CSF, and for obese children, it's 280. Question number 23. According to ICSD 3, which of the following formulations is not considered as a combination analgesics for the diagnosis of medication overuse headache? Answer is D, aspirin and paracetamol. Because here the drug that has been combined are two non-opioid analgesics without any adjuvant. So answer is D. Question 24, where this fat suppressed T1 MRI shows the high signal crescent surrounding the internal carotid on the left. Answer is B, that is intramural hematoma due to cervical internal carotid artery dissection. Question 25, which of the following is not a feature of post-dural puncture headache? Answer is C, that is more common between 10 to 25 years old person. So basically, other options are correct. C is wrong because it's more often seen between 31 and 50 years. So answer is C. Question 26, where a 30 years old postpartum woman has progressive headache, papilledema and a seizure. This CT scan shows empty delta sign. So we would have to move forward with MR or CT venography, which is the imaging of choice. So answer is C. Question number 27. According to ICSD 3, sleep apnea headache is characterized by all of the following except D. That is nausea, photophobia, and phonophobia. Rest other options are correct. Question 28, where a 35 years old female has severe paroxysmal headaches triggered by certain head positions with transient obscuration and one collapse. So here we can see there is a colloid cyst in the third ventricle in this image as shown. So answer is B, that immediately surgical intervention has to be done here. So answer is B and rest other options are fine. Question number 29, which of the following is not characteristic feature of ictal epileptic headache? Here answer is A, that is headache typically persists for more than 60 minutes. Rest other options are correct and the first one is incorrect. Because headache improves or remits immediately after the seizure. Question number 30, where a 56 years old man presents with acute severe headache and elevated blood pressure. So according to ICSD 3, the cutoff for the diagnosis of headache attributed to hypertensive crisis is B, systolic 180 and diastolic 120. So answer is B here. Question 31, where a 40 years old woman presents with recurrent thunderclaps headache and as shown the image is here. So the option which favors RCVS over primary angiitis of central nervous system is C, that is near normal CSF with reversibility within 3 months. Rest other options can be there in both of the following. But headache resolved within 3 months of the onset favors RCVS. So answer is C here. Question 32, where a 42 years old man experienced recurrent severe unilateral periorbital headaches exclusively during aircraft descent. Answer is C here, that is headache attributed to aeroplane travel. Question 33, where a 39 years old man has a headache that worsens within 15 minutes of standing and resolves on lying down. MRI is shown as in the following images. So this condition demonstrates spontaneous intracranial hypotension. So the correct option here would be epidural blood patch. Answer is B. Question 34, where a patient has paroxysmal pain in V1 distribution of face after touching the face and prominent conjunctival injection and tearing is there. So the option which favors shunt over trigeminal neuralgia is C, that is absence of refractive period after triggered attacks. Question 35. The formerly known entity called ophthalmoplegic migraine is now classified as recurrent painful ophthalmoplegic neuropathy, that is RPON. So answer is A, that it's actually not classified under migraine spectrum disorder. It's classified under painful neuropathies? So answer is A. Question 36. For the diagnosis of classical trigeminal neuralgia, MRI should demonstrate, answer is B, that is neurovascular compression as well as morphological changes in the trigeminal root. For question 37, a 60 years old man develops brief stabbing pain in the tonsillar region triggered by slowing, followed immediately by a syncope. So according to ICSD-3, these syncopal episodes are mostly likely due to excessive vagal activation leading to bradyarrhythmias or transient asystole, that is B. And this is a case of glossopharyngeal neuralgia. Question number 38, where a 28 years old female has recurrent electric shock-like pain lasting for 30 to 60 seconds. So here the MRI shows a white possible demyelinating plaque over this area. So answer is secondary trigeminal neuralgia, that is B. Question number 39. Which of the following correctly describes the diagnostic menstrual window for pure menstrual migraine and menstrually related migraine? Its answer is B, that is -2 to +3 days, where the first day of the menstrual period is considered day 1. So answer is B. And the last question, where this elderly man has pain distribution as shown in the image. So answer is D. Other options are correct. Pain is aggravated by Valsalva maneuver is not correct. So answer is D. So this is the headache which is attributed to the orthostatic hypotension.
Okay, thank you, Dr. Manju. So now we have completed all questions. So, sir, Dr. Francis, sir, now how do you see this secondary headache disorder? So big list. So do
Yeah.
you think a resident or any neurologist should remember this headache disorder, or if any of them should be remember, which one should be the first or second, third? I think we can't remember these all, sir. At least secondary.
Yeah, it is, I think, difficult than the first part, mastering, secondary headaches. And I think you selected very good, cases with images, and also have covered most of the secondary groups, except I think group 5, trauma is not there, and group 9, inflammation. Of course, there is primary angiitis, but that is in the vascular group, group 6. Yeah. And I think group 12, depression, we do not have much information about this depression and other psychiatric, psychological comorbidities. Most of the entities are in the appendix, these group 12. So, and these cases, I think, are rare presentation. So you may get a shock. It can come, especially the area where I practice. Maybe tertiary centers you may be seeing regularly, but in the peripheral areas, secondary setup, these are occasional shockers. Yeah, you are, totally surprised when you see some of these cases, and many of them can be missed also initially. Yeah, and that syncopal episode with glossopharyngeal neuralgia. That is why some experts think it must be vago-glossopharyngeal neuralgia. Vagus also is involved, and some people, I think, have differentiated, vagal episodes and glossopharyngeal episodes.
So, people, just same question. List of secondary headache is very big. So it could be discouraging for the student or young neurologist. So list is so big. So how to approach? So how should
Unlike,
the approach for the secondary headache, and how will you encourage that list and classification is so big for the secondary headache? And there are
unlike
so many
Francis,
confusion also.
unlike Francis, sir, I found these secondary headache questions rather easier as compared to primary. And there are two reasons for that. One is that each question has a visual clue. which actually aids your diagnosis. So if now the matter comes down to choosing your 4 options. If your 4 options are very contrasting and there is a visual clue, then the answer is easy without even knowing the exact criteria of secondary headache. So that is why the framing of question was very good. Even without knowing the criteria, I think many of the conditions could have been answered easily. There are certain questions which you cannot answer, like headache attributable to aeroplane travel. If you have not read this particular condition in ICSD, you cannot answer this question. So this is a trick question. But otherwise, most of the questions were conceptual question. Some of them were factual, like menstrual headache. Unless you know -2 and +3, you cannot answer. But otherwise, most of the questions were good. Adding a visual cue actually, I think, will add to the answerability of these questions. This is what I feel.
You have worked a lot on the trigeminal autonomic cephalagia, trigeminal neuralgia. One question regarding the criteria: secondary trigeminal neuralgia and painful trigeminal neuropathy.
Yes,
According to criteria, symptom
yes.
is almost same.
Yes. So
If it
actually,
is,
I answered this question at present time wrong. I answered it as painful trigeminal neuropathy. So I
Yeah.
remember it as a painful trigeminal neuropathy when there is a headache, when there is a cause which produces neuropathy, trigeminal, and produces pain. But I again have to relook into the precisely the criteria. It is probably secondary trigeminal neuralgia, but I am confused with painful
the
trigeminal.
criteria mention that if it is the recurrent short-lasting headache, then it is the secondary trigeminal neuralgia. But with
It is a
same feature,
prolonged.
with same feature, it is the continuous burning pain. It is a
Okay.
painful trigeminal neuralgia with the same lesion.
Yeah. So
So
actually,
is this
somewhere
differentiation required here?
I don't know. Previously, the trigeminal neuralgia used to be classified as classical and non-classical, or type 1 and type 2, where type 2 used to be a continuous pain, whereas type 1 used to be a paroxysmal pain. So that way it classifiable into secondary trigeminal neuralgia. But then there was a condition which was added later in painful neuropathy, is painful trigeminal neuropathy. And this secondary or the non-classical TN actually phenotypically now fits probably with the painful trigeminal neuropathy. This is something which I'll look into now.
And I have one more question regarding the especially MOH. You can see lot of drugs and lot of number days, number 10, 15. So how do you see that? So many drugs, so many combination,
Sir, it is
somewhere it is
very
10,
difficult
somewhere it
to
is 15.
it is very difficult to remember each drug, each combination, and number of days one has to take. I think the number of days and the number of drugs is slightly superfluous. In clinical setting, in continuation of your question that you asked after the first set, these are the conditions where the ICSD may not be very, very relevant for all. Because suppose if somebody has just a borderline duration of medication overuse, it is still a medication overuse headache because the mechanism of headache now is something different. If the phenotypically the migraine has transformed to a transform migraine, which a previous classification was there, that of a transform migraine, that the migraine becomes more like tension type, continuous, low grade, loses its phenotypical characters. And if there is super added medication overuse, if it may not fulfilling the criteria of the duration and type of drug, even that, according to me, should be categorized as MOH, and treatment of MOH should be instituted in these patients. This is my feeling.
Amit, you must have some question for our experts, panelist.
Sir, I think there is already a flood of question. Everyone is in awe. I think there is no one is in the participants are also not asking any question.
They
So
have not asked.
my comment was that ICSD is, I think they are revising ICSD every time ICSD 4 they are preparing for the ICSD 4. As you have asked earlier, also there are many gray areas in the ICSD. Many reclassifications may be required, and the headache, the pioneers of headache are looking into that. And I will ask from Dr. Francis, because he is one of the India's person of ICSD. So do you think there is some revision that is required in the current ICSD criteria? Where, well, a few points only, where do you think uh, there is something wrong with this ICSD criteria and further required in the next ICSD?
Definitely. I think we need lot more revisions. And I don't think maybe next 10, 20 years, you will be able to make it perfect. If you look at the first ICST was in 1988. So nearly 36 or 36, yeah, 36, 37 years now. And ICSD 4 is in the offing. And if you look at group 5 trauma, which I brought it out to Professor Todd, the group chair, that there is no chronic subdural hematoma. That is the one which you can get any day, which was there in ICST 2. But that was missing from 3 beta. So I wrote to him. And he said, excellent observation. We will look into it. But ICST 3, nothing about chronic subdural hematoma. And I think depression, anxiety, now we get more and more, studies from different parts of the country. And now they have come out with, classification of orofacial pain. That is a very big classification. That I think we have very minimal in ICST3 about dental origin and, temporomandibular joint and yeah. So I think, I have documented brief migraine. I do get brief migraine, and atypical migraine. So Dr. Sanjay was asking what percentage you can diagnose from this criteria. For me, in my area, I think 10 to 15% I am not able to put it into ICST3. So, but I have my own simple criteria like migraine equivalence and the transformation of migraine after 50, 60. You do not get them into that even probable migraine criteria. So I say most probably migraine, or migraine origin headache in the elderly, And elderly headache also, I think all these will be separate groups maybe later. Pediatric migraine, elderly migraine, and
Okay, sir.
maybe adolescent migraine.
So I
Thank you,
think,
sir.
yeah,
I have one question for Dr. Manju Yadav.
Yes, sir.
You have prepared this excellent set of questions. You have read almost all criteria. So
question
while
from
preparing, while
question
going
to the
through
quiz
these all
master.
questions, so what was your feeling? So many headache you have read recently.
So honestly, even I was not aware of the question that I have made. And even I was reading them for the first time. Like the questions. In fact, while framing the questions, I was like, oh, this is the thing that is happening. So everything was new to me also. So I do agree the questions are difficult because we usually don't read them during our residency days. So yes, they are difficult.
So it
So
was not read by you before.
No,
Any
sir, not
questions?
the main ones were fine, sir. Like we often read about migraine, tension type headache, but the subdivisions that are given inside them, we usually miss those points.
So do you think it should have been read in your DM
Yes, sir,
curriculum
yes,
or
sir.
not?
Sure, sir, sure, sir. There was a
So
large chunk of the things that were unknown. Like I often think like this, that we should have.
knowing is it important or not during the
It is important,
residency?
sir. It is important.
Oh, so what can we do for the residency program that is should be any idea? Any idea,
So
Vimal,
we
from
can.
your side? You are running
Yes, sir.
in the big institute, so headache is almost neglected part. So
Yes, sir.
Dr.
Yes, sir.
Manju has done from the GV Pant and Dr. Devasi sir is there, but she's not read that secondary headache books, many of them. So
We used to see
what
the
are you
questions,
doing
sir.
with your
Yes.
resident to read these all things and what other can do?
I think the mistake that I did was that we used to see a large chunk of patients, sir, but we were not, referring the ICSD3 at that time itself. As sir just said right now that we should refer the ICSD3 each and every time we see the patient. So that was missing.
Same question with Dr. Bimal. How can we engage other residents or other faculties?
So now I work in headache, so most of my residents will always refer to ICHD in OPD. It is now easily available on phone and one would refer. Many times I'll ask them to just see this patient is having headaches in night. Is it a hypnic headache? Just take history in detail and refer it to ICHD3. So referring to ICHD3 is actually very, very important because otherwise you won't be able to make that entity. No, the other thing is different. Like suppose you are working on headache day in and out, and then you find atypicalities, and then you refer to ICHD and you find that there is something discrepant. For example, this question on SUNCT versus trigeminal
Trigeminal.
neuralgia and refractory period. No, I was probably the first of the few people who demonstrated that refractory period is not required to diagnose SUNCT. So refractory period is well known in patients with trigeminal neuralgia as well. So, but the thing was dropped from the criteria, but it is written in the comment section of the criteria of SUNT. So these are the things which discrepancies will remain. There will be things which will improve, as Dr. Francis said, that with revision, the things will be taken up into consideration. Other very important thing is there, sir, that if somebody big in the field of headache has proposed something, then it is very difficult to change for even those who are making criteria. This is what I feel. So there are many things which are written. Like for example, ophthalmoplegic migraine, the Indian proponent was Dr. Lal, and this could be removed. But had it been by somebody else, nobody would have dared to remove it completely. It would have been wrapped in grays and somewhere and somewhere. So this is also is going on along with this in ICSD thing. This is what I feel. So
Thank
this
you.
is there, sir.
Dr. Ashish, can you hear me? If you can hear your input or your notes.
Yes, sir. Very nice quiz. I think I joined late. I was traveling somewhere. So whenever as soon as I got time, I joined. But really, really nice questions, and Manju has really worked very hard on this. And they were all clinical oriented questions, and I believe everyone is appreciating that in the chat box also. So really good questions, and they enhance our knowledge about the secondary headaches, no doubt. And I believe, as Dr. Paliwal said, I also feel that the secondary headache questions were much easier to do, primarily because you have some visual clue, and that helps you in reaching a diagnosis. As sir said, even if you don't know the whole criteria, no one can remember the whole criteria, I believe. So time and again, probably Dr. Francis alone can do that. But probably he's also read it so many times that he has become so expert in that. So I think time is the only thing. You read it again and again, then you will remember.
Yeah, thank you, Ashish. Now over to Amit for closing remark and thanks. Vote of
Yes,
thanks. Both you can give.
yes, sir. So, think secondary headaches is only 3 to 5%, but everyone is loving secondary headaches. It is more grave, but everyone is loving. We can see that also. We can ask the technical team how the participant performed in the primary headache versus secondary headache. So this we will know soon, very soon. So thank you, everyone. After this wonderful and eliminating headache quiz, I would like to thank the IN President and Secretary for giving us the platform to present this knowledge fiesta. I would like to thank our panelists, Dr. M.V. Francis and Dr. Vimal Paliwal, sir, for the wonderful discussions following the quiz. Would like to thank Dr. Sanjay Prakash, who single-handedly conceptualized and formulated all the questions along with Dr. Manju Yadav. It is his concept of doing this. I think this is not to scare the student. This is to make them more aware. They may not 100% get the marks, but they will be more aware, more interested, and more inclined toward the headache medicine with these types of quiz, because these were not being done and headache is neglected in the earlier thing. Huh? So he single-handedly conceptualized and formulated all the questions, and Manju Yadav supported her. I would also like to thank our IN digital team, especially Ashmita, who conducted the webinar, and she made the quiz very easy for all of us. And finally, I would like to convey my deep gratitude to all the participants, attendees, and all those headache enthusiasts who attended and participated in this quiz. So thank you, everyone.
Just a minute, just inform when will you declare the result, and
Yes, sir.
how would participant get information?
So I think it will take 3 4 days. So possibly Monday, Tuesday, we will be able to get the result, and the top three will get the certificate. And so we will declare the result individually who are the winners, and also on the IN headache subsection WhatsApp group. So we'll convey it to everyone after getting the result, possibly Monday or Tuesday.
Okay.
So thank you, everyone. Good day, and thanks for joining in this quiz. Thank you.
Thank you, Francis, sir.
Thank you.
Thank you, Vimal.
Thank you.
Thank you, Amit. Thank you, Manju.
Excellent
And
use, and
thank you,
big
Asmita,
thanks to Dr.
for all
Sanjay
your
and
support.
Dr. Manju for these very thought-provoking, and it was a revision for me also. And thanks to Dr. Vimal, Dr.
Thank you, sir.
Ashish, and all others. Thank you. Thank you.
Thank you so much, sir.
Thank
Thank you,
Thank
Ashish
you.
sir.
And we will meet again after IN. There is no meeting before IN's conference.
you.
Yeah.
So there will be headache subsection meeting only after IN meeting. So
When you are there, we can expect, many more such ICSD
hope
sessions here.
hope we will get.
So we will
Okay.
need support of all of you, sir.
Okay.
Thank you.
Okay. Thank you, everyone.
Thank you, Dr. Amit.
Thank you.